Good afternoon. My name is Jacqueline Schell and I'm a psychiatrist working at the dependency clinic in Linköping. And my role today is to introduce the speaker of this afternoon. And I'm very proud to present to you Thomas Lundqvist, who is a clinical psychologist and a PhD. And he has devoted his time to studying the psychological effects of cannabis use, and he wasn't satisfied with just doing that. He also, from that studies, invented a way of treating these effects, and not only that, he also has worked on spreading this method of treatment all over Sweden. And not only that, he's also now devoted to evaluating the effects of this treatment. So in Sweden, you cannot underestimate his influence on the treatment of cannabis use in Sweden. It's very important for that. So please, Thomas. And also, I have to say some practical things. Thomas has to catch a plane, so he will be leaving us about 10 till 3, but we have a lot of time. But just to be sure, if you have questions, don't hesitate to interrupt him. He has promised that you can do that, and he'll try to answer your questions. Okay, please, Tom.
That was a very welcome, Justin. I would like to employ you for the future. First of all, I would like to thank the organizer for inviting me to this conference, and that you are here after lunch. And if you go to sleep, I will see that. And I will throw a couple of good jokes and probably also a neuropsychological assessment if something's going on in the brain. And I will present in English, which a lot of Swedes are very happy, because I'm from the southern part of Sweden and we have a dialect like those in Texas. So being a psychologist sitting in front of a cannabis user is difficult, because you have a face expression, which means that he has no problems, he's well functioning, and I don't need to help him. And sometimes that's true, but sometimes it's not. So today's lecture will be on that group where it's not true. So you will have a small walk through the brain imaging literature, and you will have a small, very small, because I know that Professor Mandras will address this issue tomorrow about the growing adolescent brain, which we learned recently, it's only 7 years ago. And after that, you will listen to when I describe the psychosocial treatment that we use in Sweden, Denmark and Norway. Prosperously. So when I try to give a presentation, it's always, now we will see if it's working. Oh yes, I need to use cartoons, and I use cartoons when I talk to my clients, because this is a way to make abstract concept concrete. And the first cartoon is the screen of the cheese dome or Teflon brain effect, which is coming up during the acute state of intoxication, and accordingly to how often you smoke, commencing on surfacing after about 1 time a week of use, after about 2 years, and you will have a complete screened off situation on the qualitative sense of communication. The second cartoon is scrutinizing yourself, correcting yourself when you're making mistakes. If you can practice, you don't need to do this now because this is an official lecture. When I have students, I always tell them to practice silently their own alphabet, and then you say it out loud, and then you say every second syllable loud. So you have to jump over one, which means that you need to have executive functioning working, and most of you will not succeed. That's why I don't want to test you here, because then the man is focusing on the ceiling, saying this is not a man thing, and the women are looking cute and giving us a quick laughter. So you can practice tonight doing this. You will all notice that you are not able to fulfill the task, and that's the outermost intellectual function that we people have, together with some monkeys and dolphins, where you can see that you are not doing well in this issue. And the third cartoon describes flexibility in thought, which means that you can have different things going on at the same time without losing the train of thoughts. And you will also have a dialogue with the surrounding social people. And if you don't have it, you will only have monologues and you will not have dialogues, especially not during the first 2 weeks of detoxification. All these things you need to know as a therapist. If you don't, you will speak to someone who hasn't picked up the phone and you haven't noticed it. So this is the lecture I'm going to do. This is just a summary. But of course, I went to Paris recently, so why not use Baudelaire? What has you give with one hand, it takes away with the other. That is to say, it gives you power of imagination, it takes away the ability to profit by it. In a more thorough way, we can describe this through brain imaging studies. So what I would give you is imaging cognitive deficits in cannabis users. After that, psychosocial treatment, and finally improvement in psychological and social competence, because you need to know if you have done your homework well. There has been a lot of studies going on, but you need a perspective, and I have chosen the clinician's perspective to present this, because that's what I'm understanding. So I will hope that you will do that too. You can divide it into resting paradigms, cognitive challenge paradigms, extended washout period, and you can also look specifically look at the growing adolescent brain and neuroadaptation and stress and dysfunction of hippocampus and amygdala. It's not good knowledge. Cannabis is doing things to the growing brain that we don't want it to do. And of course the associative memory. From a clinician's perspective, every issue should be focused on the associative memory, because the temporal lobe is a very slow in its reorientation process. We have known for a couple of years that you have subnormal cerebral blood flow, metabolism in long-term cannabis users. Looking at those who are chronic intoxicated, not acutely intoxicated, and we can see that we have a decrease of oxygen transportation with about 9%, which is considered a discrete figure, but still, for a lot of people, hazardous in thinking. If you give acute exposure to marijuana, it's a dose-related increase in cerebral blood flows. That's how the blood flows in the brain among experienced users, which means when you have used cannabis and achieved the level of a chronic intoxication, which is above a certain level, and you smoke again, you will have a small peak, which means that the chronic user are confident and secure, and he knows that he needs to smoke cannabis because that's good for him, because then he's going to be able to focus and consider and compare and so on. Especially in the part of the brain which is above your eyebrow, which is associative part of the brain to the hippocampus. You also see that other regions increasing their activity are involved in some kind of communication, except for memory, which means that you are not able to retrieve memories from either the time where you were chronic influenced or the time when you were acutely influenced. So it's really a Teflon brain on the episodic memory system. That means the memories that you gather when you're here in Stockholm, looking at the Queen this morning, which is a memory for our self-knowledge, and you will bring it home and you can bring it up whenever you want. You don't do that as a chronic cannabis user, which means that the part of the treatment is to retrieve situations where you had something to remember, so we can create kind of fake memory about this. We have also used a working memory task with no sensitivity after 24 hours of washout. They showed a diminished activation in the dorsolateral, it's here, prefrontal cortex, which means that's where you are aware that you exist. It's here, if you didn't knew that. So if you want to get hit, turn the side on so it hits you here. Otherwise you will lose your knowledge of yourself for a couple of hours. And this is still diminished after 28 days of the washout. If you continue, so marijuana disrupted both sustained and transient attention processes, resulting in impaired memory task performance. If you should use attention and look at things, you need to have the episodic memory, because you are not able to view things that you don't know. So when you are using cannabis frequently, 3 times a week, over 6 months, for example, you are just watching. You are not taking in what you're seeing, you're just watching. And if you're doing that through the teenage years, you have nothing to remember when you decided to quit when you're 22, 23 years of age, which is normally when you decide to quit. If you have started in early teenage years, 14, 15 years of age. The greatest difference between users and controllers occurred in brain activity related to episodic memory encoding. Of course, interfere with the individual subjective history. And so on, and so on. There are substantial studies and results, of course, showing that this is going, so this is nothing to debate. We know that for about 20 years. And no one are able to compensate for that kind of impact. We have a washout problem when we are doing studies, so there is a kind of discussion of how long should they have abstained before we put them into the brain imaging hood. And we have a minimum of 3 days. But we also have studies that show that we could have deviant results because of the prolonged extended washout period, 28 days by Julian Todd, a very eminent researcher from the United States. And so on, we have, for example, 28 days motor cortical circuits, which means if you are going to think about legalization and that you will be able to drive car or airplanes like I will do tonight, this afternoon, I don't hope the pilot smoked yesterday, because then he's not going to have a perfect touchdown on Gardermoen in Oslo, and we will land in Bergen or something. Anyway, this motor cortical circuits makes that you are not good at using brakes when you see things. And we don't know for how long for each individual that this will create a problem. So you are not able to use motor vehicles 28 days after being smoking cannabis. Of course they do. So it's a problem in traffic. And we will discover that when we have the techniques to look for it. Yeah, we don't need to go into that deep. If you have a normal job and you are a chronic cannabis user, and you can go along and say, well, I only smoke in the evening, I don't smoke during the days. So they can't say anything at my job. So if they come to me and say, well, we can. Because you are always competing with yourself, because you are not able to produce information at the same level as you should have being sober. So it will, of course, have an impact on your daily life and your work experiences. And you may also have the problem that you are have a higher IQ, which means that you have an intelligence capacity, a general intelligence capacity which is above normal. Then you can allocate energy from different parts of brains and train the brain to compensate for the parts where we have a decreased activity, which means that you're remodeling the neuropsychological network during this period. And this is one of the issues that we have to deal with when we have treatment with chronic cannabis use, to remodel the neuropsychological network. It works. It's cognitive technique. Well, in 2007-2006, Fulton Cruz produced a paper on the adolescent cortical development, a critical period of vulnerability for addiction, which meant that which had the impact on me, the effect on me, that I had to change my perspective as well and put on my clinical observations and the results from several studies into different kind of structure. It means that you become more diverse in your way of thinking, more qualitative, more sincere. You have improvement in hippocampus, amygdala, nucleus accumbens, as well as in prefrontal, frontal and orbital area, which means that you get more civilized, which you all have noticed when they change from 14 to 15 years of age. You can have them in one room together. The prominent reorganization during adolescence are not fully exploited, and we need to know more about this. We know, for example, that the endocannabinoids are involved of the migrations of the neurons so that they come together and form a bundle which is more powerful. It's like hooking up to the internet, if you remember back in the 90s, where we have a modem 28.8, we can listen to the connection coming through, and then there was silence and nothing happened, because we had nothing to do on the internet in the early 90s. But today we can retrieve film. Not a very interesting one, but a film, and look at it, and nothing happens. It's practically the same as in the early 90s. There is a question to answer. Will you reorientate in your brain development so that you are able to get back to the adult brain level? I hope Professor Madras will bring up that subject tomorrow, because we are not there yet to give the answer. If you had had 10 years of cannabis use between 14 and 24 years of age, that you will be able to create an adult brain function after that. You will live the rest of your life imitating adult behavior. We have, of course, a couple of neuroimaging studies where you can see that recent cannabis use is associated with decreased activation and the frontal cortex during an emotional stress task. This is not good, because if you have an emotional stress task, you need to have external control to cope with that. you are not able to build up internal control and solve it by your own. Also, you have the reduced amygdala reactivity to social signs or signals of threat, which means that you should be aware of how you are behaving in a social context. And if you are performing wrong, stop before you do it, because you are realizing that you are in a social dangerous situation. And it's called maturity, usually. So this is one of the issues that we bring up in the treatment programs. Just changing colors, see if you are awake. 16 to 18 years, adolescent marijuana users. After 28 days, monitor abstinence, suggesting different approach to spatial working memory tasks. This is not good in a way, because if you are 18 or 19, you need to have this kind of network in optimal function, because then you have to adjust according to the society you live in. If you don't have it, you don't adjust to the social life, of social surrounding community that you live in. You will become a dropout. You can also see that if you do studies on American students from college, and this goes for European as well, of course. If you compare normals to those who use cannabis, you can see that they are not developing frontal temporal connections, which means that you are not training your associative memory. You are just like this, looking through a funnel. And this is not good if you go to school. You need to have associative memory. So, we know that it may affect the trajectory of normal brain maturation. And the future studies are there to help us to see if we can look at that. For example, when we are 30 years of age, if they have gone through treatment, abstained from cannabis, if they are well functioning. We don't know that yet. The final part of this section is early start of cannabis use is associated with increased cortical activation in adult cannabis users, possibly reflecting suboptimal cortical efficiency during cognitive challenge. So it means that you are trying to do your job by working harder, and that will probably help you. The working memory system was overactive during a novel task, suggesting functional compensation. If you use your working memory, as you do now, you are able to do that for as long as my presentation is on. Afterwards, you have to have cigarette or coffee or think of nothing, and then you go back and you can get alert for another hour or so. We are optimal when we are trained students, about 4 hours a day that we can use the working memory system on that. So this is more like I said before in the beginning, a kind of Teflon brain function. Associative memory is kind of your knowledge of what happened before and what kind of solution you have to the problems that you face every day. And you need to have a kind of tools, a toolbox to create solutions for every problem that you face. And Jagger studied non-acute effects of frequent cannabis use on hippocampus-dependent associative memory. And he found that cannabis users displayed lower activation than non-users in regions involved in associative learning, which means that all learning is associative, especially for us who are grown-ups. We are more than 24 years of age, I can see. And some of them of us are above that with a distance. I don't want to say who. He assessed the brain function in frequent but relative moderate cannabis users in the domains of working memory. And they performed equally well during the working memory task and the selective attention task. But not when you are looking at associative memory, which means that you are learning wrong, because you are not connecting it to old structures and problems. This is a NIDA brain. You see it's pink receptors, so it's probably a female brain. It's a joke. You're not accustomed to that kind of jokes, I see. As a matter of fact, we have a paucity on knowledge and studies on women using cannabis. And I hope we will in the future see more studies, especially in the development of internal control. You have an input. It's concentration, attention, ability to elaborate and store new information. And then you have an output where you process complex information, planning and temporal activity or capacity, understand opinions and ideas of others, ability to reflect, compare and consider. And you need to communicate that in your psychological network the whole time. It's called elaboration. And it comes through anterior cingulate, which you can describe as the place where you show who you are as a character. Yeah. Putting cannabinoids into the system, it will create enhancement of the CB1 receptor, which makes the GABAergic system unfunctional, which means that you are fragmenting the neuropsychological network. So you can display a lot of symptoms. As you well know, there are no CB1 receptor in the ventral tegmentum area or the mesolimbic system, which means that the dopamine release will be immense because there are no GABAergic system that holds it back. So it's turning up the volume without no effort. If you go into the recently used synthetic cannabinoids or CB1 agonists, which are not provided for humans, they are more for Lewis rats in the labs, they are not turning up the volume like the natural plant THC, it's doing it more. and without the compensating systems in the plant, it will cause a very harmful effect on the neuropsychological network, which we are experiencing today as a chemical experiment on our youth, which I wrote an article recently in Swedish on that issue. Anyway, what happens is that you fade away. If you do, will you do that, please? Yes. You fade away, and you don't have face expressions because the amygdala is not sending out any signals that you are happy, that you are sorry, that you are confused, that you are focused, that you are interested, or just polite, listening to what I'm saying. And if you are doing that, you will not be detected because we can't see you. And that's one of the problems that we have detecting cannabis users, because we can't see them in that sense. Turning up the volume in the system where you create feelings is of course why you smoke cannabis. And at the same time you turn down the volume in the executive functioning, which means that you are not thinking, you are just enjoying life. This is what it is, nothing more. Because there is a lot of CB1 receptors and GABAergic system in that point. So it closes down the shop. It doesn't matter. Amygdala, it's a place where you have some kind of reorganization or organization of emotions, expressing those emotions through the affects in the muscles of your face. It doesn't matter if it's cold or warm. You don't produce signals in that communication, which means that you don't have a social way of living. If the family, your wife or your friends not fine with that. During the teenage years, you should decrease the dependence of external control and train up your executive functions and attention, impulsive control, mental flexibility, structural incoming stimuli, and temporal integration. So you create internal control. With the internal control, you can cope with emotions created by inner and outer stress. If you use cannabis during that period, you are not developing that kind of internal control, which means that you are coping with inner and outer stress through using more marijuana. Yeah. So, can you treat this? Yes, of course you can. We have been doing that since 1984. And this is available on www.droginfo.com in English. We also have a guide there. Well, do you want me to tell it again? Okay, 3 W's, okay, it's well known, then a dot, then not drug with a U, with a O. Yeah, well, it's Swedish. droginfo.com. And you can retrieve a lot of information in English. And we also have, I heard that we had Russians talking today. We had this treatment program in Russia. I don't know if they are aware of that, but we have. Right. Looking into different studies of psychosocial treatment to see what kind of method is the best. I reviewed in 2005 13 studies, and as you can see there, one from Sweden, that's me, there's another one from Sweden, and then we have Australia, Jan Copeland. There are a lot of differences in the figures among how many people we assessed. And we have an evidence from 1 to 5, which 2 and 3 are fairly good. And we have an experiment control design which are not comparable, because they are going wild, doing things that they can do just to be able to do studies. So you can't use it. So what I did when I looked into this, because some of the knowledge and the results are, of course, good, and we can use it. We don't have to invent everything yet. There's one thing in the scientific community that I do not understand. They think cannabis is the same as alcohol. So if you use cannabis every day, a month, and you go through a program, and you use it after the program, only 15 days, there are no difference in your functioning. And you can't put that as a positive result in the study, but they did. You need to learn about the chronic influence and the effect of 11-hydroxy delta 9 THC's effect on low activity in your psychological network. So what I did was I was looking at the things that we had in common. Well, it's cognitive behavioral technique, an educative technique. You have to learn and teach the cannabis users what cannabis does to you, so he can reflect, compare, and consider about the fact. Of course, motivation interviewing. And if you want, a combination of these. We also saw that a built-in flexibility to offer care to patients of all ages was necessary. Dennis and Roberts showed us that. A brief intervention which has significantly larger reduction in substance-related problems with the lowest severity class, few sessions. And this is not 2 sessions, it's 6 sessions. Because if it's 2 sessions, it's mainly seeing a person twice. And that's not a treatment. A more comprehensive intervention, which works better with high severity clients with at least 14 sessions. In our program, we have 18 sessions. With follow-up sessions, more often at the beginning. We also saw that subtle impairments in cognition within their agenda work towards their illusions, which means that you need to know as a therapist what kind of subtle impairments. We have to have a focus on immediate abstinence and the possibility to have urine samples taken voluntarily. Of course, sessions from family members and significant others. The possibility of long-lasting cognitive deficits that affect both the performance of complex tasks and the ability to learn, which means we have to have subjects or tasks that they have to fulfill and come back and tell us that they have done that. Focus directly on use itself and at the same time help to improve the accompanying deficits in competence. Help to critical examination of the drug-related episodic memory. As a therapist, during the 3 weeks, the first 3 weeks, you are a prefrontal substitute, as you are to your small kids and grandchildren, if I look at you. Some of you will have small children. You are a prefrontal substitute until the prefrontal brain kicks in between 4 or 6 years of age. It's good knowledge to have. Strategies to enhance self-esteem that is not based on drug-related episodic memory, because you are not able to have access to the drug-related episodic memory when you are abstaining. You have to smoke again in order to be able to retrieve the memories, which means that you only feel emptiness for 3 or 4 weeks. And additionally, you will have emptiness because the body do not produce endocannabinoids. And endocannabinoids binds to the same receptor. So if you give cannabinoids from the outside or synthetic cannabinoids from the outside, the body says, okay, I have vacation. I don't produce. And if you have been using regularly over a month or 2 years or 3 years, the body decreases the production of endocannabinoids, which has an impact on your subjective perception and your memory and your sleep and a lot of things that the endocannabinoid system is responsible for. You need a set of adequate questions to enhance the recognition factor, because you are not able to retrieve just out of blue sky. You have to have a cue. There are some good studies on that subject too. Why treatment? Well, the chronic influence on the cognitive functions, the impact of increased subjective perception as a result of acute intoxication on the emotional system, the need of professional guidance in the relearning process and regaining stabilization of the cognitive functions, critical examination of the drug-related episodic memory, and to promote psychological maturity. The need to enhance the social competence and orientation to life in order to be able to go for more mental health in your daily life on your own. Compensating for immature brain development, which is like going to, when you have some fixed your arm, you have to train it again to get muscles again. And this is the same with the brain. If you don't use the brain, if you relax, in Sweden we can relax 6 weeks in the summer. And you can think of that with envy, but you can also think of that, of what kind of work we have to put in to get back being relaxed for 6 weeks. No, it's better if you don't only have 2 weeks. The causes that lie behind the self-regulating use. We know that up to 60 to 70% of the young teenagers use cannabis because they want to regulate anxiety, depression, traumatic issues, and so on. So we have to focus on that issue when they have abstained that long, that they are able to have good discussion on the matter. And they need to be given proposals, because they are not going to do it by their own. So we are using this kind of pharmacological cartoon, trying to illustrate the elimination process of THC. If you're not familiar with that, there are books on that issue, already written in 1986 by Professor Stig Agorel. And if you consider coming to my office and you have stopped using the evening before, you will have about a half-life of 5-6 days of the potent 11-hydroxydelta-9 THC metabolite, which goes back into the system and into the system in working again and taking away the abstinence. So if you have a cannabis use, you are not noticing any abstinence, because then they are washed out. The abstinence is washed out with the long-term effect of the metabolites. So it's a very kind drug in that matter. And we have a biomedical focus with 3 sessions a week, where you focus on headache, cold and warm sweating, after that we see, after 2 weeks, a rise of anxiety and emotions, which means that someone wants to put a question, a difficult one. Okay, thank you. We have one question coming up. So the psychological focus begins when you don't have enough cannabinoids in the system to push down on have a low activity of emotions, and so they arise, the emotions arise. And you are not used to that, and you probably don't have the capacity of internal control to keep it. So you show that. And we have discussions about that. The memory, the short-term memory, will start functioning in about 2 weeks of cessation. And then you go over to the third phase, which is the psychosocial phase, which has a never-ending limit, which is continuously developing. And the issues we have on this is that we take responsibility for 6 weeks, which is the complete elimination process. After that, you have to decide if you want to go on and have our help with psychosocial issues. A lot of clients choose that to continue. You have a question, no? Well, I can always continue, but... Yeah. Yes, please.
Hello. First of all, my name is Nina Karapushansky. I'm from Brazil. And I loved your presentation, because also I know many of these works that you mentioned, but it's so good to have them all and see recent bibliography. My question is the following. Many times I'm asked to participate in debates on TV programs or radio programs, and there are like 3 or 4, there are 4 drug use, and then 1 person that is against. And they keep saying lies, it's lies. When I have to talk about cannabis, and they keep saying, no, because it's a soft drug, because it doesn't do much harm, because when you tell a youngster that his brain will go nuts, that's not true. What, from all this that you said, because so many different things that are proved, what would you say would be something that would make impact to say, no, when a youngster uses, or somebody uses cannabis for a longer time, cha-cha-cha-cha, something you would choose to say, what would it be?
I have chosen not to take part in those debates because you need to have a discussion with someone who has his inner ear on, that he's listening to your arguments, and if it's closed, he's just using affirmative or confirmative information. He are not able to elaborate on the negative effects. He can only see the positive effects. So let him have whatever arguments he wants to have. So if he wants to say, it's a soft drug, what does that mean? You should ask. No, you should ask. Because then he has to present facts. And you can say no. It's like Björn Borg and Vitas Gerulaitis playing tennis in the 70s. 5 hours and nothing happened. But we have color TV, so we can look at the red marble. Now, you can also ask them, cannabis is medicine. Okay, we have one, it's Sativex, which you, no, maybe not, yes, you can use it, but they haven't been using it since 89, 90, when we thought that we could cure AIDS with it. You're not using it for chemical, when you are having cancer medication and so on, because there are others. Yes, there are lots of studies that show us that this is not optimal. So, we have one. It's rimonabant, it's a inverse agonist of CB1 receptor, which is SR 141716A, which was very good for obesity when the body is in danger, but not for me. I have a very central overweight right here, yeah, but it doesn't work because my body is not in alarm. So every time you use cannabinoids in medications, and it should act, the body needs to be in alertness, alarm. It's dangerous. We need to help because the endocannabinoid system is a protective system. So it's not used anymore because doctors prescribed it for me or someone else who didn't need it. And then you only get mood down regulation. So it's a difficult question. So they had gone to sleep already when I talked so long, but this is what it's about. And well, anyway, there is only one thing that you can ask them. If you are very convinced that you are not on a negative development using cannabis, so please let us put you into a brain imaging machine, and then you quit for 6 weeks, and then we put into you to the machines again. You have an individual comparison, because it's individual. They can only interpret individual information. So, in the first time, don't go into that kind of discussion or debate, because it's a kind of social communication for adults. In Brazil, as in Sweden and everywhere in Europe and elsewhere, we have certain authorities who are there to cope with the issue, if it should be legal or not illegal. If we have the discussion over one beer or a glass of wine, fine, it doesn't matter, because they will not listen to us. They are only looking at scientific data, as they do slowly now, concerning synthetic cannabinoids. So, do you have a suggestion of an answer to your own question?
I always try to use these things.
Yeah.
There is no time for the public.
Yeah.
This is the show.
There's always one against, and then 3, 4. Yes, because you can count. 3 is more than 1. It's very concrete. Yeah. And then you have someone in the middle who are very liberal and anarchistic. So it's a 45-minute debate on TV and nothing's happening. Yeah. Well, anyway, we have an original model for those who are about 24 years. It's like an eclectic model where you have to pick up for the individual, each individual issues that fits with his kind of character. And we have a manual-based model for those who are between 17 to 24, which will have one manual approximately late September. I'm optimistic. Because this has been one, from my book, or that when you read on the website, this model has been used for a lot of people who are telling them now they are using Lundqvist's model. So it's like going to get a good credit at the bank if you use Lundqvist's model. And it became very wide. So what we did was we put together a lot of skilled social workers who have been using this model for at least 10 years. And they wrote it down and we are now processing it. It will only fit for those who have used 3 times a week in 6 months. From 17 to 24 years of age. Then we have a shorter version, which also lies on this fundament, but it's only 6 weeks, 6 times, 2 times a week or 1 time a week. And you can use it for those who are using synthetic cannabinoids as well, if you know what synthetic cannabinoids do to your brain, because the education part is very important. And you have a cannabis discussion, which is more for parents who are detecting that their kid is using cannabis, so they need to come longer than start with that discussion of this is a medication, this is a soft drug, and blah, blah, blah. So we help them with structure to have a good conversation over the kitchen table. Turning down the volume on the TV set. We have, of course, a guide in 11 languages. We have Russian, Persian, Dutch, No one wanted to have their names on the Dutch guide. It was dangerous, they told me. Okay, I'm not scared, I'm a Viking, so I'm not scared. This is a self-help guide. You can retrieve it from the website, and it's in English, of course, and in Spanish. Not in Portuguese, no. Yeah, right, sorry about that. Because the woman who helped me was actually from Brazil, but she transformed it into Spanish. Yeah. Feel free to do it in every language you want. We miss Arabic languages. We don't have Arabic languages. So if you can't, 11 pages, it's very easy. French, Danish, Norwegian, Finnish. You should read the Finnish one. This is good. You don't understand a word. So we have an introduction, because everybody needs to know what they are doing, because if you are meeting a young adult, they don't know what treatment, social treatment, psychological treatment is. They know that if they take a pill, the headache goes away. So you have to have a kind of introduction to describe what's happening and why you should when go into treatment. If you don't want, we have motivational sessions. It's called problematization, which means tearing down the walls of defense. It's easy. Then we have, of course, the extended part when you are finished with the elimination process and the brain is on the level of practically normal functioning. You should go on and improve your social competence. And it's a kind of score, a score which means that you should take the structure to you and create, on the basis of the knowledge and the structure, your own model, which means that you show that you are understanding how to treat him or her. And, well, this is for those who didn't understand mine. This is the website. And then you have the Finnish one, if you want to, and the Russian language and Persian language. It's a score, it's a defined basic structure. It implies an individual creative process of the performer. You have to work for it. It's working on the logistic framework of 7 cognitive functions that you have, that I have, that we need to have in everyday life. Verbal ability, logical analytic ability, psychomotility, analytic synthesis, psychospatial ability, and gestalt memory. So the guide is asking questions about all these 7 functions and dysfunctions. This is what I said before. It addresses the chronic influence, the impact of enhanced subjective perception, the need of professional guidance, critical examination, promotion of psychological maturation. This is just a repetition of repeating myself from the earlier part of the speech. It's necessary that methods dealing with chronic cannabis use contain these aspects. As a therapist, you need to have a good knowledge of what cannabis does to you. You need to have a concrete and simple language, and that's not easy, because you're all trained in abstract thinking and visiting meetings and expressing yourself you get points if they don't understand you, because then you are too intelligent. It doesn't work. Using illustration of screen of conditions and so on, focusing on notice what's happening, compare with earlier experience, reflect and consider the topics of the discussion, which means that you are trying to get your associative area in shape. The first step, solve anxiety reactions, resist the desire to escape back, coach the defective capacity of learning, reveal the specific thought patterns of the patient. It's described if you retrieve documents from the website. And topics discussed in step 1 or phase 1, the home situation, the process of change, the representation of the future. If you should have a representation of the future, you have to have a representation of the past in your memory system. And you need to understand the issue today in order to pick up important things and put into the future. It's a process that grows along with the detox process. The last phase is to help the patient to understand components of developmental process, and to elucidate the basic conflict. Why are you using this? Why did you throw away 10 years of your life? Question. And to live with that. To help the patient realize the difficulty in changing strategies. And consider himself as a part of the society. How does he handle the vulnerability and sensitivity? And plan for the future. This is 18 sessions used at the Maria Youth Center here in Stockholm. And it's a part of the manual that we are producing. So there are another 10 years of evidence. They have been using that since '99, and it's working. Using cannabis as a young adult, as a naive person, is creating a rush comparable with being in love. And if you're being in love, it takes you a couple of weeks and you just love. You don't have the enormous volume on its way. So you get used to the love and live with it, and you are secure and you know what's happening and waiting for you when you get back and so on. And you marry, of course. And at the same time, at a certain time, you realize this marriage is fake. We are not a good couple. We are not an idol. Same as you do. You don't know why. Just one day, it's in your brain, it doesn't work anymore. So you decide to break up for a short while. And then you don't have the negative feelings about this, and you only have the good feelings, so you go back. It's relapse. And then you notice this is not good, and then you take the decision into the treatment program and say, I'll quit. I have to learn and live with my ex. And they do. And then a lot of them, they just walk away from the ex and they don't think about it anymore because they don't need it. So this is the way where the improvement in psychological and social competence kicks in. And we use cellular genetic theory, which means that a good sense of coherence is that stimuli deriving from one's internal, external environments in the course of living are structured, predictable, and explicable. It's comprehensibility. The resources are available to one to meet the demands posed by these stimuli. Manageability. And these demands are challenges worthy of investment and engagement. We call that meaningfulness. It's a 29 item questionnaire where you have Swedish statistic significance of a good sense of coherence when you have the results between 142 and 152. When you have high on comprehensibility, manageability, and meaningfulness, and a profile from the meaningfulness as an emotional motivation to go on with your life. It's a very nice. In my thesis, 100 years ago, I looked in and I said they had 118. They had low comprehension and high manageability and high meaningfulness, which means that they are convinced that they can handle things they don't understand. And they live screened off from a situation where they automatically move towards a good sense of coherence and mental health. If they abstain for 2 weeks, 6 weeks, and go into treatment, they have 142, which is normal for Sweden. And you have high and high and high, which means that you have gone through this in a very good sense. So does this happen if you just stop and do not go into treatment? No. I've also included those who have abstained for about 6 weeks, 40 days, and they stopped at 125, which is more than 2 standard deviations from 142, which is significantly lower. So if you quit cannabis, please go to treatment. In Maria Youth, my study was on those who were 30 years of age. In Maria, we have 17 years of age. And you can see at admission, they had 118. After 6 weeks, 138. And after 1 year follow-up, 144. Which is a stable result of the treatment program. And along with that, the comprehensibility went over 4, and of course manageability and meaningfulness. So we are very proud of this result. And Uppsala is another university city, as we call it in Sweden, because I'm from Lund, which is the first university in Sweden, I think, but it was not, because we belonged to Denmark at that time. I don't want to bore you with that fact. So they were looking at adults, and they found the same, 119 and 135. 135 is okay after 6 weeks, and 142 and 152 was the standards of Swedes. So also in comprehensibility and manageability, meaningfulness, and we can do this one time after another. We will come up with the same results. It works. That's why they're using this program. It works. We don't bother you with that. Symptom checklist 90. So my take-home message: recent results from brain imaging studies indicate that chronic cannabis use during the adolescent years will create problems in adjusting to society. and that you should create a cognitive program to help them. Thank you for your attention.
I suppose we have time for short questions. Anybody? Please.
I'm Kathy Gindle from the Centre for Policy Studies. I do appreciate that you have built in a proper evaluation in your own terms, in terms of the measures of comprehensibility, coherence. I fear dealing with policymakers and even addiction psychiatrists in England, they would demand a different type of evidence base in order to convince, for somebody like me to begin to convince them that this was a good way to proceed. Do you have follow-up evaluations of the, especially of the youth, which age was it, up to 19, in terms of more long-term abstinence?
Well, 1 year is the longest that we have.
And do you have evidence of their abstinence?
Yes, we have evidence of their abstinence. The problems I think that you will have is that they criticize this model because it's not randomized control study.
That's one problem. Probably many won't even
So
be aware
tell me any randomized control study usable in daily work of drug addiction. I haven't seen any.
But you will be well aware
Oh,
that
yes.
the British are totally narrowly reliant on it in a sort of blinkered, totally blinkered way. I did have another question. In terms of the practice over the 6-week program, how does it fit with a child's or a teenager's schooling? You have 3 sessions a week. I wonder how it's managed.
At that time, if you go to school when you're 16, 17 and 18 years of age, it's not very intense. So you can always find small parts in your schedule that you can go for.
And who motivates that? Do you as the treatment people, or do you expect the school to cooperate?
It depends.
And again, we'd have organisational issues.
It depends. If the school has a good psychosocial program, we will work with them. If they don't have, we don't work with them. Because
you mean at all? No child from that school would come to
yes, of course, the children are always welcome.
Yeah.
But we don't work with the school. Then we work with the teacher and ask the teacher if he could give extra teaching, an hour a week or 2 hours a week during that period where he has to be focusing on getting right in his own life.
Thank you very much.
Yeah. There's another one.
Yes, my name is Gunnar Grunberg. I'm here as a journalist. I'm just wondering if you get a teenager to treat a heavy smoker and a heavy cannabis smoker as well, does it mean some problems for you just to persuade the person to quit cannabis smoking, or do you want to? Because I think my experience is that a heavy cannabis smoker is a smoker as well, and if you stop to smoke cannabis, it's easy to get over to cannabis again because you are a smoker.
Cigarette smoker.
Yeah, of course.
Yeah. First of all, if they are under 18, we have to tell the parents that they are seeing us. And we of course ask them if that is a problem. And then we ask them how they get their cigarettes, of course, and how they smoke, if they want to quit smoking cigarette as well. Just to give them thoughts of considering and reflect and compare why they smoke and how often and so on. It's more easy to quit cannabis than quit nicotine. nicotine is a very nasty drug. And you were addressing kind of craving issue. And as far as we know, is that if they relapse into use, it's because they are not psychologically mature to cope with the reality. So that's why they relapse. Not because they are using cigarettes, smoking. Anyway, I think I have to leave you because I have a flight to catch with a good pilot. And it was very nice to present this.